we are live in 5, 4, 3, 2, 1. We are live now.
So good evening, everyone. On behalf of Rajasthan Orthopaedic Surgeons Association, I am Dr. Rahul Kotta, Honorary Secretary of Rosa. Welcome you all for this another webinar, master classes in hand surgery. So today's topic is the flexor tendon injuries, and we have a galaxy of faculties to address this topic. And today's session would be moderated by Dr. Amit Vyas and Dr. Narendra Saini. So to start the formal proceedings, I would like to invite the President-elect of Rosa, Dr. Kishore Chandani, to say a few words and formally inaugurate this webinar. Over to you, Kishore, sir.
Thank you so much, Rahul, and thank you very much, my dear colleagues and friends who have come to attend this. And most importantly, we have one of the best faculties. We have Dr. Rajendra from Nashik, and the moderators are the stalwarts of hand surgery in Rajasthan, Dr. Amit Vyas and Dr. Narendra Saini, and not to forget Dr. Purnima Patni, who is the pioneer in one of the pioneers in hand surgery. So she is also there. We are very lucky to have her here with all her experience, and one of the best faculties we have, Dr. Vinit Arora, Dr. Aviral Gupta, Dr. Iqbal Khan, Dr. Rahul Khanna, Dr. Mukesh Garg, and of course, Dr. Vinay Goyal would be joining us shortly. And I welcome you all to this one of the best in hand masterclass in hand surgery. And I formally, on behalf of the Rosa, inaugurate this session, and I hand it over to Dr. Amit Vyas to moderate it. Thank you very much.
Thank you, Dr. Kishore. Over to you, Dr. Amit. You first introduce the faculty and start the proceedings of today's webinar.
Yes, sir. So, good evening, everyone. So today is our master class on flexor tendon injury. It is a pertinent subject, and it is a quite troublesome if not treated properly. So Rosa official told me to conduct this webinar, so we will be more aware about this condition. And for this, we have invited our guest faculty, Dr. Rajendra Nehete sir. Dr. Rajendra Nehete sir, he is basically hand and reconstructive and microvascular surgeon. He is working at Vedant Hospital, Nashik, and he has worked enormously in hand surgery field, and presently, he is president of Indian Society of Reconstructive Microsurgery, and he is president nomination Asia Pacific Federation of Association of Microvascular Surgeries. And I have worked under him as an executive committee member when he was secretary and treasurer of Indian Society of Surgery of the Hand, and he was the secretary and treasurer of the brachial plexus surgery group of India also. He has conducted a lot of national and international conferences, and he has numerous publications in field of microvascular surgery. And his identity is about the microvascular surgery, and he has presented a lot of guest lectures in various national and international conferences. So with this, we have with us our Rosa official, President Dr. Vinay Goyal sir, Vice President Dr. Kishore Chandani, and Dr. Rahul Kotta. He is the Secretary Rosa, and Madam Purnima Patni, Madam is our mentor and teacher, and she is President of Jaipur Hand Surgery Association. And with this, our faculty, Dr. Vinit Arora, he is working at Jeevan Rekha Hospital, Jaipur. Dr. Aviral Gupta, presently he is doing his fellowship from the Singapore, and Dr. Rahul Khanna, he is working at GBH Hospital, Udaipur. He is a senior orthopedic surgeon. Although his area of interest is arthroscopy and arthroplasty surgeries, he is presently executive committee member of Rosa. And I also welcome Dr. Mohammad Iqbal sir. He is senior orthopedic surgeons and he owns his hospital at Kotta Trauma Hospital. And then my co-moderator, Dr. Narendra Saini sir, he is associate professor at SMS and Surgery Unit, Jaipur. So with this, I would call Dr. Rajendra Nehete sir to start his presentation about flexor tendon injuries.
Yeah, good evening all. Dr. Patni, Dr. Kishore, Dr. Vinit, Goyal, Dr. Rahul, Dr. Narendra and all colleagues. I'm so happy when Amit called me saying, you please talk to our Orthopedic Association masterclass. But I was surprised that he gave me a flexor tendon. I thought he would give me some toe transfer or some microvascular topic, but he gave me a flexor tendon injury. And I would like to share my screen. And thank you for inviting me for this webinar. So I work at Vedant Hospital. It's my private hospital, 30-bedded tertiary care unit in plastic reconstructive surgery and hand surgery. And we do all the spectrum in plastic surgery, but my passion is about hand surgery and microvascular surgery. And that's how I am into this. See, when we see such patient, a complete compartmental injury, what result do you expect? Obviously, all of us expect that it should be a normal. And this is his post-operative result: complete extension, complete flexion of the fingers, touching the palmar crease, and complete flexion of the thumb. And this is his video. Though he is not flexing completely in the wrist crease, because this video was taken by my assistant, is a good functional result. Do we get result in such all the cases? And probably the answer is no. And that is why we keep discussing about flexor tendon injuries again and again. But then I think if we deal the flexor tendon injuries properly, I think all of us should get equally good result in each and every case. But then why don't we get result is because mainly I feel it is because of the adhesions. And any healing process creates an adhesion, and it is because of the fibrin-laden glue. And Watson-Jones used to call this as a physiologic glue. Actually, this glue is created in the process of healing to favor the healing so that the tendon should heal early. But the same glue which is created by nature for good healing, it becomes a problem for surgeons. And we should be able to avoid that problem. So how do the adhesions occur? At the repair site and along the length of the flexor tendon. Sometimes the adhesion will occur on the dorsum of the fingers and hand, because there is always in the operated hand, there is an edema, and that edema will settle down as a glue. And it will lead to tethering of the flexor extensor tendons on the dorsum of the fingers. And it will be detrimental for the result of the flexor tendon repair. So can we prevent this glue from adhering? So the answer is simply, you mobilize the tendons. And it should be immediately after the repair. But then there is always a risk of rupture of your repair if you try to mobilize them early, because the normal strength of the tendons is achieved at 3 months. Then what is the answer? We'll go through it. So the goal of flexor tendon surgery is accurate adaptation of the tendon ends to allow tendon gliding. So it should be accurate so that it allows a good gliding. It should allow primary healing of a tendon. There should be nothing detrimental in between it. One of the reason for not a good primary healing is infection and non-approximation of the tendon ends properly. Inhibit the formation of peritendinous adhesions. So if we have achieved first two aims, then obviously it will inhibit the formation of adhesions. Then stimulate the restoration of gliding surfaces. There are many papers in a recent literature. We are trying to use some drugs to avoid the adhesions, but then it is still not possible to avoid adhesions completely. And ultimately, our aim is to restore normal range of motion of all the fingers. So what do modern principles do? They improve the tendon healing and they avoid the tendon adhesion formation by making the repair strong enough to move early after the repair. So if you want to improve tendon healing, you should be able to mobilize the tendon as early as possible. But then you have to make the repair very strong enough so that your repair doesn't give way. And that is the only thing at present which can avoid the adhesion formation. So the practical considerations in flexor tendon repair is tendon suturing technique, the core suture what we take, and the circumferential epitenon suture what we take, and avoiding the pitfalls depending on the site of injury, because there are zones of flexor tendon injuries which will come to it, and a good rehabilitation of the flexor tendons. We should always think about the vascular supply of the tendon. So the area which is on the dorsal side of the tendon is supplied by the central artery. It is the end artery. So any injury in between this artery will hamper the circulation of the tendon. The superficial anterior or a flexor palmar aspect of the flexor tendon is supplied by the synovial fluid by the diffusion process. So if you don't want to strangulate the vessels which are mainly in the dorsal area, your core suture should not go into the dorsal area of the flexor tendon. It should remain into the anterior half or a palmar half of the flexor tendon. It is very, very important. Then you have to take care of the flexor pulley system. We know, all of us know this pulley, anatomy of the pulleys. I will not go into detail, but out of these pulleys, the pulley A2 and A4 are the most important pulleys because they will avoid the bowstringing of the flexor tendon when the flexor tendon is flexing. So it is important that you should locate these pulleys A2 and A4 and try to keep them intact so that you get a good result of the flexor tendon. So what is the biomechanics because of pulley? The 9 centimeter of tendon excursion is required for complete wrist and digital flexion so that your fingertips, they touch the palmar crease. So it is a 9 centimeter and 255 centimeter of full digital flexion with wrist stabilized. So when you stabilize the wrist in one place and do only digital flexion, it is 2.5 centimeters. So tendon excursion and joint rotation are controlled by pulley system. It is very important that these pulleys should be kept intact. You should remember this biomechanics. It has got very pertinent on, it has got a importance in getting a good result. So this is a moment arm pulleys. So loss of pulleys will increase the excursion necessary for desired flexion. So why your A2 and A4 pulley should be kept intact? Because if there is a bowstringing, it will need a more excursion of the tendon, and that excursion is not possible because we are dealing with the fixed length of the flexor tendon and muscle, whichever is required by nature for that particular length of the hand and finger. So if we don't keep this pulley intact, obviously the tendon excursion will be more and finger will not flex. It will not completely go into the palmar crease. While dealing with the flexor tendons, it is important that when you examine the patient should have this normal cascade of the fingertips. They should lie in one line. Most of the time, what I observe is index finger is little outward than this cascade, most of the time. But then when you see the flexor tendon injury, it looks like this. So whenever you see, many times, because this is important, because we get patients who are already sutured outside and they come after 10 days and 12 days with a loss of cascade. So that time, if you find any finger which is going out of cascade, it has got a flexor tendon injury if it is injury on the palmar aspect of the finger or the hand. Secondly, once you see this patient, you should observe the tenodesis effect. With the wrist passive extension, normally the finger will flex. That is because of the normal tenodesic effect. If they don't extend on the wrist flexion and if they don't flex on the wrist extension, that means there is a problem with flexor tendons. I will not go into clinical examination detail because all of us know it very well. But when you examine the FDS of the middle finger, you have to control the other fingers. So ring and little finger should be controlled in extension to check the FDS of the middle finger. Similarly, because the FDS of the middle ring and little finger has a common belly. When you test the FDP, you have to fix the PIP joint and then see the terminal flexion. For example, this is the FDP rupture. There is no active DIP motion in the ring finger. Though it can be passively flexed, but actively, patient will not have a flexion of the DIP joint. Other clinical examination is very important. There should be a good skin integrity, palmar as well as dorsal. You have to do a good neurological examination because if there is a nerve injury, you have to repair it. You should do good vascular examination to assess the vascularity of the fingers. You should see the bony integrity by either angulation or rotation of the finger. These are the zones of the flexor tendon. Zone 1, I will not describe them because it is available in the literature. I will straight away go to zone 1 injuries. Zone 1 flexor tendon injury is called also a Jhsa finger because the commonest modality is when the patient is removing Jhsa, the finger gets caught into it and there is an avulsion of the flexor tendon from the distal phalanx. Zone 1 injury is classified by lady. So ladies classified, type 1 is retraction into the palm. So it is avulsion and directly goes into the palm. Type 2 is retraction to the PIP level because of the vincula, it remains at PIP level. Type 3 is bony avulsion with the tendon attached and type 4 is bony avulsion, tendon not attached to bony fragment. They are separate. What is more important in zone 1 injuries? Your repair should happen within first 7 to 10 days. Otherwise, you'll end up in more problems. So types of repair is as a direct repair if the laceration is more than 1 centimeter from FDP insertion. So you have 1 centimeter of distal segment of the FDP if it is a laceration. If it is a avulsion, then you have to insert it. So if there is a laceration and you cannot advance a tendon if it is around 1 centimeter because it will have a quadriga effect. So avulsion repair, what we do is similar what has been described in the textbook. So I'll tell you a trick. What I do is I take the Prolene suture or ethylone suture and put the two ends around the distal phalanx and come out of the nail. So the needle size required for this is more than 20 mm. Commonly 24 or 26 mm needle is sufficient, which goes around the bone and comes out of the nail, and I tie a button on it. So previously I used to try to drill holes through the bone and get onto the nail, but now I go around the bone and get it. This is a similar patient. She had no flexion of the middle finger at the DIP joint. She wanted a good result. So we inserted it. You can see a button. Many times I put a blouse hook on it so that you can put a traction on it. But that was my old method because I used to give a Kleiner's traction that time. I no longer use a Kleiner's traction, so I use a button now. And this is the end result. In spite of that, you will find there is incomplete flexion of the DIP joint of the middle finger. And you can see in an extension also, patient is not able to extend it completely. So it is the deficit in the flexion to some extent. And this is the result. You can see a good flexion of the DIP joint though. And obviously the patient was extremely happy with this result. Another patient with FDP avulsion, and we take an incision. I prefer a Brunner's zigzag incision. And then you retrieve the tendon because it was into the palm directly. But then if the patient is presented late, after maybe say 15 days or 3 weeks, and still you want to insert the flexor tendon, so what happens if it is retracted completely into the palm? The pulley system and the flexor sheath, it contracts to some extent and it doesn't allow a complete FDP go in. So what I do is I do Hemi Fdp Repair. So I will divide the FDP into two and use discard one slip and pass one slip in the flexor sheath by a railroading technique and insert it. And this is his result, but still you will find doesn't have. This is one surgery which many times will not yield to absolute normal result. So tendon advancement, which was previously advocated for zone 1 repairs as moving the repair site out of sheath, was failed to decrease adhesion formation. But however, if you try to do that, there is shortening of the flexor system of that finger, there is contracture of the finger, and you get a quadriga effect. So what is quadriga effect? Is like what the 4 horses, and if you pull one horse more, the other horses cannot function. So with the quadriga effect, you get a loss of grip strength because the other flexor tendons will not work properly. Is there any role of DIP arthrodesis? Yes, definitely. Whenever I have a patient with FDP avulsion, if the patient is manual laborer or a non-skilled worker, I just explain them that even the DIP arthrodesis can give you a good result. So we do DIP arthrodesis in 5 degrees of flexion, and you can have a good result with that. However, whenever you do DIP arthrodesis, as orthopedic surgeons, you know, it is not very simple. Again, you have to be really careful when you do DIP arthrodesis to get a good result. Coming to zone 2 injuries, this is one of the most controversial topic, used to be. And zone 2 was supposed to be a no man's land. And because if you try to repair FDS and FDP both, the stiffness after repair was very common. Even now also we get stiffness after repair in zone 2. You have to remember zone 2 injuries mainly because of the knife injuries, when particularly if somebody is attacking other person and that person flexes his fingers on the knife, or somebody is trying to cut fruits or something, and during flexion if it gets cuts. So you have to remember, if the injury is during flexion, the proximal ends are pulled proximally and the distal end will be distally, more distally. So you have to be careful to notice it. If the injury is in extension, then the proximal tendon are retracted more, the distal tendons are not retracted more. It is a clinical whenever you try to locate the tendon after the injury. So many times you get partial lacerations in zone 2. And why not repair a partial lesion? Probably reason would be to avoid risk of scarring of the tendon, because partial laceration as it is will heal. So what is advocate? The 25% you can just bevel the tendon so that there is no question of adhesion. 25 to 50% you should do a peripheral repair, just repair the EP tendon, and that's sufficient. And if it is more than 50%, then you have to take a core suture with peripheral sutures. So this is a patient with zone 2 injury, a complete tendon repair. So we explore it, repair it. You can see on table there is a good cascade. This I always check on table whether we have achieved a good cascade. The fingers should be in the good cascade in the wrist extension as well as in the wrist flexion. Then that means the flexor tendon is moving. If it is not moving in the flexor sheath primarily, then that means it will definitely get adhered and it will not function properly. So you will have incomplete. So do we repair FDS and FDP both or just FDP? So the advocated is at present repair FDS and FDP both, but somehow I tend to repair only FDP in many of these patients because many of these patients, one, they don't primarily come to me. I mean, sometimes they come after 4 days, 5 days, or maybe after maybe 15 days, or even if they come primarily, there is some contusion in the area, and in contused sheath, I have experienced that it will always get adhered and will not have a good result. And so we try to repair only FDP. You can see a photograph out here. There is no good DIP flexion after the repair of FDS and FDP. And there is little bit of flexion contracture. So we give the dynamic extension splint and continue, ask the patient to flex it completely. And ultimately, you have to, in a zone 2, I have realized the physiotherapy protocol goes almost up to 6 to 8 weeks minimum. Patient has to come daily to the hospital or at least alternate day so that it is well monitored. Otherwise, they don't get good result. If they disappear for even a week, the adhesions are very strong and the flexor tendons will not move. So what gives the ultimate strength and what is the good repair? So it is proportional to the number of strands. So 6 to 8 strand repairs are the strongest repairs. But the problem with this, there is increased bulk and resistance to glide, and there is increased tendon handling and adhesion formation. So may not be necessary for forces of early active motion. So what we do is we use a 4-strand repair, and that gives us adequate strength without complexity of 6 to 8 strand, because I have tried to do 6 to 8 strand also. The complexity goes on increasing, the bulk goes on increasing. So we do only 4-strand repair. There are obviously complications like stiffness, re-rupture, tenolysis may be required. So re-rupture we don't get now because I always see to it that I have done an extremely strong repair. But stiffness, yes. Tenolysis, if it is required, should not be done earlier than 3 months because it will not give a good result. And if it is indicated, if there is no improvement in the range of motion for 1 to 2 months, it has become static. Zone 3 injuries, lumbrical muscle bellies usually are not sutured, but if you repair, it is better because this can give a lumbrical plus finger. We'll go to zone 4 directly. In zone 4, the tendons are rarely cut because it is well protected, but there is no contraindication to repair at this level. This is the patient presented us too late. After he was already operated somewhere, he had a flexion like this. Thumb was flexing very well, but finger flexion, you can see, was very poor. So we explored all the tendons, almost were gone. The median nerve was repaired to one of the tendons. The ulnar nerve was left. It was not repaired. So we did all the repairs, and this is his final result. So if you are careful, you can always get a good result in such patient, a complete flexion and complete extension. This is his video. You can see scar on the ulnar area also. He doesn't have a claw hand. The injuries are, the nerve also are very well repaired. It is relatively simple, but the problem is there are multiple tendons. So sometimes the identification of tendons become difficult, but you have to know your anatomy of flexor tendon very well so that you don't do this mistake. There is extensive handling. So in fact, you should handle them very carefully and you should reduce the handling so that you get a better result. Many times you will find that there are different sheets for the tendons. And normally whenever I operate in this region, I don't disturb that sheet. I just remove that, pull that tendon through by a mosquito forceps, repair the tendon and leave that sheath intact. Or in fact, take a suture by 6-0-ethylon on that sheath so that the individual tendon lies into the flexor sheath. And similarly, there is a sheath exists for the common muscle belly of FDP also. So if you don't disturb that sheath, you will have an excellent result. This zone 5 comparatively easy. The only problem in this zone 5 is you have to repair the nerves very well. If you don't repair the nerves very well, you will not have a good result of this. So this is complete flexion and complete extension. Again, it is a muscular region. In muscular region, it is very important to dissect these muscles individually, repair all the muscles individually. Don't take the chunk of the muscles and repair. It will not give a good result. So individually and repair will depend on how well you notice the epimysium and repair that epimysium. What I do is I take a core suture with thicker vicryl like 30 and then take 60 ethylon for the epimysial repair so that it becomes really smooth and slides well. And you have to, this was devascularized hand and this is her hand, complete flexion, complete extension. So in Fpl repair also, primary repair obviously is indicated, and usually the Fpl retracts directly into the wrist. So you have to open the wrist. This is the patient who had Fpl injury, and you will find there is no flexion of Fpl. So you open the wrist, locate the FDP, and then do a railroading technique and do a good repair. Don't forget to keep the pulley intact, because if the pulley on the proximal phalanx is not kept intact, patient will not have complete excursion. Now you will find this is the post-op photo and the video. You will find little bit of incomplete flexion of the distal phalanx of the thumb, but then this is functionally, it doesn't give a problem. I'll skip few of the slides. I like the Brunner's incision, a zigzag incision. It should not be obtuse, but it should have an acute angle at the lateral border of the digit so that it doesn't contract. But you have to be careful that you don't damage the nerves and vessels out in this region. Pulleys, you need to keep the A2 and the A4 pulley intact. You should always remember this. About the suture techniques, I told you there are plenty of suture techniques. This is the Kessler suture, which used to have 2 knots on the external surface on both the ends. So it was modified. Kessler suture had only 1 knot inside the flexor tendon. Now disadvantage is if you take the knot inside, it adds bulk to the tendon. But then I also always take care that the knot is inside, because I feel if the knot is outside, it rubs on the other flexor tendons or rubs inside the sheath and it produces more adhesions. This was Kessler Tajima using 2 knots. So suture knot location, if it is inside, it interferes with the healing of the tendon because there is a bulk of knots added into the tendon substance. If you keep it outside, it interferes with the tendon gliding. So you have to judge what you can do better. And I think if you follow one technique properly over the years, you start getting better and better results. So the sheath is very important. As I told you that even I try to repair the sheath in the palm or in the zone 4 also, and in the wrist and the zone 4, because it is barrier to the extrinsic adhesion formation, and there is rapid return of synovial nutrition. Because of the sheath repair, the synovial nutrition remains around the tendon and they heal early. Technically, it is difficult, but I think for a hand surgeon, there should be nothing technically difficult to repair this. Post-op rehabilitation, there is a risk of stiffness or a risk of rupture. You have to judge. Too much of motion will lead to a rupture. Too little motion will lead to a stiffness. So why mobilization is important? Because it prevents the adhesions. The adhesion will be tendon to tendon, the other adjoining tendon, or it will be tendon to a scar of the skin. So there are various protocols. We know one of the most famous protocol was Kleiner's protocol, where there was active extension and a passive flexion by rubber bands. Durand modified it by controlled passive motion methods, and Strickland started early active motion. What I follow is early active motion starting next day of the flexor tendon repair. All aim at full active range of motion at 10 to 12 weeks. So I will not go into details of the Kleiner's traction. We know it very well. And thank you very much. we would, as Dr. Rahul said, we would like to discuss more rather than showing some theoretical mold results. So I showed only one case in one zone. Yeah, thank you, Dr. Amit.
Yeah. Thank you, sir, for very nice and elaborative talk. First of all, I would like to ask you a question.
Yes.
That do you found any difference if you repair zone 2 FPL repair and other finger repairs? Means in the results.
The main difference is FPL is the only one tendon in the pulley. So it becomes little easier for mobilization and the chances of adhesion formation are less. But in the finger, it is different. In zone 2, there are two tendons, and FDS, if it is repaired where it is bifurcated, so you have two slim thin strands of FDS to be repaired, and that adds bulk in the repair. And that is why I said if the FDS and FDP both are injured, many times I prefer to repair only FDP and I excise the part of FDS. In FPL, obviously the single tendon is there, so you don't have to worry about it. That is the main difference. I forgot to talk about what suture material I use, and I think it is very important because recently in the literature and by companies also, the Ethibond was being promoted to a great extent because it is obviously a stronger material. But my experience is different. I have gone back to again Prolene and Ethilon, and to be frank, I use either a 30 Ethilon or a 40 Ethilon. They have a cutting needle. That's the only disadvantage because you may cut your thread, which is while doing a 4-strand repair. I don't like Prolene because Prolene you need more number of knots, so it adds bulk in the tendon repair. Because I use a knot which remains inside the tendon substance. So that is why I prefer Ethilon. 3 knots are sufficient and I'm very comfortable with it. And if you do a 4-strand repair, it gives adequate strength. I always use 6-0 Ethilon for epitenon repair, which gives me exact good approximation of the epitenon and the mobilization becomes very easy. That's what about the suture material. I tried to use Ethibond. I had a bad experience. One, the allergic reaction to Ethibond is much higher and flexor tendon doesn't allow that much of allergic reaction. It will not sustain it. Secondly, my rupture rate has increased when I started using Ethibond. Plus, there were 1 or 2 cases of infection. So immediately within few cases, I abandoned Ethibond and I'm back to using Ethilon. Any other questions?
Yes, sir. One question for zone 4 flexor injuries.
Yes.
So anything about the transverse carpal ligament, if you wish to repair it or?
Yes. What I do is, if it is favorable, I would do a jetplasty and repair it in a lax manner rather than making it very tight or leaving it. I don't like to leave it completely, but for the obviously to avoid the post-stinging effect. But I try to do jet approximation. So you take an oblique incision and suture it. So if you are taking incision like this, then you suture it like this, so that at least there is some carpal ligament which is restored.
Yes, sir. I think because nerve injuries is also there. So yes, we are going to repair it in a little bit of flexion of the wrist. So the bow stinging or the bunching out of the tendons. So just to prevent them.
Yes. Another point, important point, I did not talk about it. Whenever I splint after the repair, I always keep the wrist into neutral position. And I always found keeping the wrist in neutral position keeps a position of the tendons in a normal position rather than flexing it more acutely. Because if you are flexing it more acutely, there is increased pressure in the wrist joint in the carpal tunnel, and in fact that promotes more adhesion. And secondly, patients find it more difficult to mobilize the tendons. I always keep wrist in neutral position. so that the mobilization of the tendons become easy.
Sir, how does your post-op rehabilitation change with any associated nerve injury or bone injury that needs fixation?
Yes.
The flexor tendon injury in zone 2.
Yeah, it is zone 2 is very important. Now, for the paucity of time, I did not include actually the cases where there is a fracture as well. There is a nerve injury and arterial injury, because I am doing a lot of replants also. So my strong this thing is, whenever there is a bone injury and there is an open injury, I would like to fix the bone with intraosseous wire plus axial K wire without crossing any joint. If it is a close injury and the bone is not accessible openly, I always put cross K wires without crossing any joint so that I can mobilize it completely. But I'll tell you, I have now achieved a good finesse in fixation with cross K wires, so that, and it both the K wires, if they give a 3-point fixation properly after putting a cross K wire, it doesn't rotate and it doesn't allow movement at the fracture side. That is about the fracture. About the nerve repair and the arterial repair, actually, whenever we splint the hand, what I do is, all the patients, I splint them in a neutral wrist and allow the flexion, MP flexion. So even if you have repaired the nerve and if you mobilize, because of the MP flexion, there is no tension on the nerve. So I'm not bothered, because I take around 4 sutures of 9-0-ethylon or a 10-0-ethylon for the nerve. So I'm not worried about the nerve repair giving away. So I don't wait it. Except for arterial repair, where I'm worried that I had to excise part of the artery and there will be little more traction on the artery if I mobilize it fast. So I will wait for maybe but only 4 to 5 days till the finger survives. If there is no excision of the artery, I mobilize them the next day, because I have already flexed the MP joint and there is no tension on the repair of the artery. So my basic tenet is, if you mobilize flexor tendon as early as possible, they will not lead to adhesions. And I use early active mobilization starting immediately next day post-op. And I do 10 times active flexion and active extension, but the position is this. So patient is only able to do this and this. After 1 week, I extended the splint up to this point. So midway between the extension and flexion, and patient is doing this movement. And after 15 days, it is completely extended. So for next 1 week, patient is completely flexing and completely extending. At the end of 3 weeks, I remove the splint and ask the patient to mobilize active as well as passive. 5th week, I ask them to do against the blocking flexion. So you will be surprised. Many of my flexor tendon injuries don't go to physiotherapist also, except zone 2 injuries, which I compulsory send them to physiotherapist next day after the repair. But no other zone injuries I send to physiotherapist. If required, if there are certain amount of adhesions, I'll send them to physiotherapist for physiotherapy. But I follow a supervised regime by myself, and I'm very comfortable with it. Many patients, they try to resist it, but I explain them, I give them more time and explain them that this is one of the most important thing to do. And for me, it is easy because I am working in only one hospital, so patient can easily come meet me. I have a whole day I am in the hospital, so for me it becomes very easy. But then for many freelancing people, it may not be so easy to follow up all the patients every time they wish. But then it is the way of practice what we do. Any other questions?
Sir, in zone 2 repair, if we do FDP alone,
yes.
And have you faced the issue of hyperextension at DIP joint and hyperflexion at DIP joint?
Narendra, what I do when I'm doing in zone 2, anyway, your PIP joint, the flexor sheath is open. So what I do is, when I sacrifice the FDS, I tuck the flexor tendon distal end to the palmar plate so that it doesn't allow a hyperextension of the PIP joint. And that I do with 5-ethylon suture, so that it doesn't add excess bulk in the flexor sheath also. And that is how I avoid the hyperextension.
At neutral, zero degree of extension, or
yes, 0 degree of neutral extension.
Neutral extension.
Yes, Rahul wanted to ask something.
Thanks for the nice presentation, sir. Just want to know a brief overview of the injuries of more than 3 weeks duration. How do you do it?
More than
3 weeks duration.
Yeah, 3 weeks duration. Now, this also I couldn't include. If there is because as we say, beyond 2 weeks, your patient will start getting the myostatic contracture of the muscle, and the tendon length will not be adequate to repair, especially the FDP. Now, again, what I said about if it is FDS and FDP, especially in the flexor sheath, I will repair only FDP. So in those cases where I find the tendon length is little shorter, what I do is intramuscular lengthening of the tendons by doing multiple cuts at 1 centimeter apart into the intramuscular portion of the tendon. But then you have to explore the forearm proximally. I take a straight vertical incision, explore that tendon. Inside the muscle, you take multiple cuts and keep giving little traction on the tendon, but traction should not be given to the tendon end. It should be given proximally, maybe almost 1.5 to 2 centimeters proximally. You catch hold the tendon, because if you try to catch the tendon at the distal end, try to pull it, you will fray the end of the tendon, and repair will be almost impossible, or it will be a very bad repair. So I never try to catch the tendon end by artery forceps or any forceps. I always hold them little away from the injury site and give a little bit of traction. After doing the intramuscular lengthening, you get around 0.5 centimeter increase in the length, and most of the time that is sufficient. But if you find that there is a more delay and more shortening or more scarring, there is no other way than doing secondary flexor tendon reconstruction. Either you do a primary tendon graft or you do a secondary tendon graft after using the silicone rods.
Any experience of two-stage tendon grafting?
Yeah, in fact, I have, Amit knows my presentation. I've done many cases of secondary flexor tendon reconstruction using tendon rods. I use a silicone rod of 4 millimeters in adults and 3 millimeters in children. But then you have to be, this surgery is not very simple. I have realized that if there is any crush component in the finger, or if there is any scarring, excess scarring in the palmar aspect, then you will not get good result by doing a secondary reconstruction of a tendon using two-stage reconstruction. If the scarring in the palm is minimal, scarring in the finger palmar aspect is minimal, and you have kept the sheath intact very well without damaging the A2 and A4 pulley, and then put a tendon implant and passively mobilize everything well. If there is any joint stiffness, again, you will not get a good result. So hand has to be absolutely soft and supple, and you have to do repair within 2.5 months. If you try to keep it for a longer time, the flexor sheath around whatever is formed, it becomes too tight and it becomes too tough that it will again have adhesions. I have burned my fingers by keeping it for 3 months, 4 months. Sometimes patient did not come, or sometimes initially I said it will be better if we keep it for a longer time. But if you keep it for a longer time, the sheath which is formed around the silicone implant, it becomes too thick and it contracts so well after putting a tendon graft that it gets adhered. So it is very important not to keep it more than 8 weeks. So around at the end of 2 months, I think within 2.5 months, you should be able to put a tendon graft into it. And you have to explain this very well to the patient, that you cannot keep distance of more distance between the two surgeries more than 2 months, because many patients, they feel that ये तो डाला है बाद में करेंगे, 3 महीने बाद 4 महीने बाद करेंगे. And sometimes they have financial constraints, sometimes they have some family problem and they will not report you. But you have to insist that if you want to have good result, you have to follow this very carefully.
Rahul Katta sir. Any other faculty have any questions? Rahul Katta sir, Dr. Kishore Chandani, Patni madam.
Another point is a simultaneous injury to the extensor and flexor tendon. So if it is there, in fact, I do the same thing. I splint them into same position and start mobilizing them, except when it is up to zone 4, because I also still struggle to repair the extensor tendon up to zone 4. Zone 5 onwards, it is quite simple like flexor tendon. But up to zone 4, that is basically on the proximal phalanx, still I find difficulty in mobilizing them and getting a good result. Sometimes I have to do adhesiolisis in the second stage to get a good result.
Sir, many of the orthopedic surgeons are watching this webinar.
Yes.
And in your practice also, you would have seen, we would have also seen many times these injuries come, they appear very simple, and a few tendons are visible in the skin and they half-heartedly suture it, and then the patient is left for mobilization, and then patient returns after a period of say 2 months or 3 months, and then a whole exploration is done, excision of the ends is done, and then repair is done. What is the message you would like to give to all these people, or all the people who are not well versed with this flexor repair?
I think the most important is you should have a good knowledge about the anatomy and physiology of the tendons before you embark into any flexor tendon surgeries. Whenever I see any patient done by somebody else, and if the cascade is not maintained, whatever day it is, if it is not being done by a hand surgeon who is experienced into doing such things, I advise revision surgery to patient immediately. I tell them there is no fault of a surgeon, but if your cascade is not coming, I feel it should be re-explored and repaired very well. I have, in my experience, I have benefited and my patients have benefited by this, rather than asking them to do physiotherapy and waiting for a longer time, because the opportune time of a good repair is lost again if you ask them to come back after 1.5 months or 2 months for a revision surgery. And that time you advise a surgery. So I many times I tend to advise early surgery. Obviously, some patients don't follow, some patients will follow. Some patients will say that he just wants to operate, so he's advising. It doesn't matter. But afterward, in the long run, they realize that what surgeon was talking primarily was a proper thing, because he had a chance that time to repair me again.
I have one question, sir.
Yes, sir.
Basically, it's a question for the from the surgeons, orthopedic surgeons who are working in the peripheral areas, and they don't have access to the proper hand surgeons within the vicinity.
Yes, sir.
So if a patient comes to them and it is obvious that the patient is having some kind of flexor tendon injuries, so what kind of message you want to deliver to them, whether they attempt some kind of tagging repair, or should they send them to the proper hand surgeon, which may take another maybe 24, 48 hours or maybe up to 72 hours because patient has to travel and arrange. So what appropriate timing should be there and what should be done at the primary level?
Yes. I think if a lot of mucosal areas exist where there are orthopedic surgeons working, they are not used to repair the flexor tendon very frequently, and they get a patient. My say about this is, if you are not very comfortable, don't try to repair tendon, don't try to tag them also, because Many times I have seen that when patient comes from mucosal areas, they use 2,0-ethylone or a 2,0-proline or 2,0-vicryl to tag, and that damages the flexor tendons. So it should not be done. And sometimes I have seen even the nerve being tagged with such a thick suture. So they should not be tagged. But if the patient is poor enough who cannot travel to a specialized center, then we always get such patients. That patient is poor, they don't want to travel to far off distance, they don't want to go to specialist. You can obviously repair the tendons. My only thing is you should give your best to repair it and try to give best of the result. And if the patient is from a good family who can spend money, you have no reason, there should be no hesitation to send it to an expert person, because ultimately the first surgery, what it can give a result, no secondary surgery can give that result which matches the first surgery. So it is very, very important.
So what deadline? Because the patient usually asks, sir, when to go to a specialized surgeon. So although it is better, always sooner is the better. But what is the time limit where you can give a good result?
Sir, I have repaired even at 4 or 5 days also and given the same result which I can give primarily. Because if there is no infection in the wound, if everything is good, you do a good repair and start mobilizing them. Even flexor tendon repair done at 4 or 5 days will give the same result as the primary repair. And I'm sure in 4 or 5 days you can travel to any corner of the world now.
Yeah.
Sir, do you find if patients in zone 5 with nerve injury, associated nerve injury, rehabilitation is difficult?
No.
Because,
yes, go ahead, please.
Because what I noticed that as you also told that you keep the MP joint flexed, and
yes.
if especially if ulnar nerve injury is there,
yes.
he will not able to extend the PIP joint because intrinsic muscles are not working. So how it influence your rehabilitation?
No, in such cases, obviously the patient will not be able to do a finger extension, but then the long extensors are intact. So when the MP joint is splinted into flexion and you are asking the patient to extend, the long extensors will act because MP is fixed into flexion. If MP is open, then the long extensors will act on the MP joint. So it doesn't matter. As long as you are flexing the MP joint at 90 degrees, the long extensor will act on the PIP joint. So that is what we test, no? The integrity of the long extensors in claw hand, whether the long extensors will work on the PIP joint. And I don't find any difficulty in that. So as I said, if there is no excision of the nerve or there is no excision of the artery, there is no shortening by surgical measure. If there is a normal length maintained, just by putting the MP flexion, it is adequate to relieve the tension on the repair. So you need not be worried. Only you take little 2 more extra sutures for the nerve, and that will not give a problem. Now, if I do a nerve repair in proximally, maybe at the level of the wrist or at the level of the distal wrist, then what I do is I take a continuous 8-0 epineurial repair. Initially, I was young, I used to enthusiastically try to do fascicular repair, but I don't think it carry any meaning. If you have matched the nerve ends together very well by looking at the fascicular anatomy, and if you are able to avoid any sprouting of the axons outside the repair, and if you are repairing it well, I think it gives an excellent result. And the approximation is also so well that it doesn't give a problem unless there is a loss of the nerve. If there is a loss, then you may have to do wrist flexion and do other techniques, mobilize the nerve proximally, because you can mobilize 40 times of its diameter without hampering the blood supply, except the branches will be there, so you have to take care of it. But then there are ways and means of doing it, achieve ultimately a good nerve repair. If there is a loss, you get segmental injuries by the knife also sometimes. If there is a segmental injury, you can definitely do a good tendon repair. What I do is, if it is a shorter segment, I pass the suture through and through that segment so that there is only one repair and the segment lies in between the suture. So there are no two repairs. It's a one repair. If there is a loss in the nerve, immediately you put a nerve graft. Don't try to pull the nerve too much, and don't try to repair under tension. Put nerve grafts immediately, have no tension so that you can mobilize the tendons immediately.
We are getting a lot of patients where especially in zone 4 and zone 5, where only tendons were repaired and nerve referred for the nerve repairs.
Yes, all of us get such patients.
Mm-hmm. So how much delay you do?
See, if the nerve is not repaired by the record of the surgeon, by the surgical OT notes, if there is no mention of the nerve, my frank policy is either me or my assistant surgeon. I have two plastic surgeons working with me. One of us will call that surgeon and ask him whether you have repaired the nerve. We are very frank about it, and we don't hesitate to call anybody for that matter. We ask them if they have not repaired the nerve. I will advise patient that you need to go for nerve repair as early as possible. So we will explore the hand immediately and do a repair without waiting for mobilization of the flexor tendons and without getting final result, because as early you do the nerve repair, the better will be the result. So we don't wait for it. If there is no mention and surgeon is not talking about it, in spite of that, if we will wait for maybe a month, we will see whether there is advancing Tinel sign and explore the nerve. Sometimes we have done the ultrasonography of the nerve also. We have an excellent musculoskeletal sonologist. Even I do musculoskeletal sonography because my wife is anesthetist. She has a machine for regional anesthesia. So I have started doing musculoskeletal radiology, ultrasonography. We do sometimes even MRI to see whether the nerve is in continuity. And if it is not in continuity, we will advise patient to operate without waiting for it.
I'm putting one hypothetical condition.
Yes.
Patient is referred after 4 weeks and flexor tendons were repaired. And patient is having, initially he was not mobilized, so he's having a stiff hand.
Yes.
And patient is specifically referred for the nerve repair.
Yes.
So
if there are adhesions, I will only see that whether all the joints, the wrist joint, the MP joints, the IP joints, then the thumb joints, they are soft, supple, mobile. That means you should be able to achieve this. You should be able to achieve this completely. If this is the case, then I will operate even at 4 weeks immediately. I will explore it. I will do the adhesiolysis. I will see the repair. If there is inferior repair of flexor tendon, I will revise it. I will do the nerve repair and start my protocol again. Not to wait. It is you don't achieve anything better by waiting for a longer time in these patients.
That many times there are crush injuries, so the skin over the tendon sheets is not looking good. The tendons are FDS, FDP both cut. There are fractures even. So, what you suggest after fixation of the bones? Should we repair the tendons or should we wait for the skin to heal in a proper manner?
You are putting me into difficult situation now because if there is such a complex injury, obviously if you feel that the skin will not survive, you need to do a primary flap. Yeah. And in fact, Amit, Vinit, they have seen my presentation. I don't hesitate to do even a primary free flap repair for even a small fingertip defects. So I use microvascular free flap transfers for even and that to a volar thinner flap from this area so that you get a glabrous skin. So my attitude is different. I am one of the aggressive surgeons who would like to do maximum things primarily and achieve a good healing. If it is not possible for orthopedic surgeon, I think they should call a plastic surgeon and get the wound healed as early as possible, because that will only decide the ultimate result of the patient.
Sir, at the time of injury, once you have taken the patient in theatre for debridement and for the fracture fixation, sometimes it is very difficult to identify whether this skin will be going to survive or not, or how much loss would be there.
Agreed.
So that is the area of dilemma when we have to decide whether to go for a primary repair of the tendons or
Irrespective
not.
of, yeah, Dr. Rahul, irrespective of,
Guide the common orthopedic about this.
I can understand your dilemma on table, what we face many times, that if the skin is not going to survive, then what is the point in repairing tendon and the nerve? But I'll tell you, we don't achieve anything by leaving the structures unrepaired. So even if your skin is not going to survive, if it is obviously going to get dead, you will know it and you have to excise it. Don't worry about it. You have to remove it, because any dead tissue which will remain behind will promote infection at the end.
Definitely.
So it is better to remove that. Do the primary repair and call a plastic surgeon for a good cover to it, because we don't achieve anything by delaying repair of the structures. That is what I always feel. As far as possible, repair them primarily and cover them primarily. If not primarily, cover within 24 hours, 48 hours. You have a time, talk to relatives, explain to the patient what is required and get it done. Because without that, we will not get good result. Many times we get patients treated like this. They are waiting for a healing, and then ultimately they come after 3 months with complete flexion contractures. Complete sheath is destroyed, the flexor tendons remains unrepaired, the nerve is unrepaired. We can't do anything in that situation. Then it becomes very difficult to give a functional finger after that. So at least if you have done a primary repair, we can provide a skin cover and patient can at least have some result, rather than having absolutely no result or having a bad finger which is non-functional.
Because nowadays it is less common, but earlier we used to get the thresher machine injuries.
Yes.
So those are the difficult
But
injuries to treat upon.
Even I now get sugarcane crusher injuries and thresher machine injuries. I face similar problem what you faced. That's true. Every one of us is facing the similar problems. And sometimes the patient is from very poor family background, and they will not say, we won't be able to afford this flap and that flap, what is to be done. But then our job, I think, is to give them the best advice. It's up to them what is to take and what not to take. But our advice should be honest.
Sir, one question for the reconstruction of the tendons. When you find wound with a gap for composite tissue loss, skins and other tissues, tendons and the nerves are lost, would you like to reconstruct a nerve and the tendons simultaneously with the flap coverage, or give a flap coverage first and then after that?
Vinit, here I differentiated whether I can get the wound healed primarily without infection. If I can get the wound healed primarily, I will repair everything. If I suspect that there might be some necrosis of the tissue, because we always find in crush injuries, nobody is perfect to notice that this tissue will not necrose and this tissue will necrose. So if you have a doubt, don't repair them, especially the nerves, because that nerve repair will not have any result. But at least repair the flexor tendon and get the finger into movement, get the wound healed. But nerve repair, yes, you can do secondarily.
For reconstruction means approx 5 to centimeter length of the tendon and nerve both are lost.
Yeah, both are lost.
Yes.
If both are lost, I think only God can help you, because it is very, very difficult to put tendon grafts. So what I have done, I have tried in certain patients, but I don't get excellent result in these patients. But I do a primary tendon implant into this and cover them with the flap and wait then. And after 1.5 months, 2 months, you try to put a palmaris longus graft into that position.
And when too much means 8 tendons are having required tendon grafting. So any tissues, facial atta or some other would you like to give grafting?
I have not used fascia lata for flexor tendons. I have used it for extensor tendon, not for flexor tendon. Flexor tendon, I always try to look for the palmaris longus. I have used FDS also. FDS, I just shred it into the 2 or 3 strips and use it. But I have not used because sometimes if there is such a crush injury, I would not like to repair the FDS. I would like to repair only FDP. So anyway, FDS I'm going to sacrifice from the wrist up to the finger level. So that same tendon is available for you. So split it into 3 segments and use it for 3 fingers. So it becomes very easy. So hardly any time I have used I don't remember I am using fascia lata for flexor tendon reconstruction. I've used it for extensor tendons.
Yes, with this, lot of queries are solved, and all are clear that we should do the primary repair. It should be done with the best hands, and if nerve repairs, nerve injuries are there and fractures are there, they should be dealt nicely, and rehabilitation should be good. And it is basically surgeons should be involved in the rehabilitation, then results can be improved a lot. So thank you, sir, for wonderful talk and discussion. Then up in the second part of this session, we will present some case scenario, and I will ask all the faculty and they should opine, and then we can basically gather some inferences. So I would prefer that there should be video on by the faculty, so they can be involved nicely. Are you able to see my screen?
Yes.
Yes, very well.
So in this scenario, this patient, he had one injury while he was opening a door, and his right ring finger had a small cut at the PIP joint crease. And then initially he went to some physician, and it was dressed. Then he presented when he noticed himself that he is not able to flex his ring finger properly. So this is the picture where he is not able to flex the ring finger at the DIP joint, and even the cut is not visible, it is healed nicely. So this is the picture. Dr. Vinit, can you elaborate the condition, what is happening, what are the examination finding?
I think the flexor digitorum superficialis or sublimis is intact because he can flex the PIP joint very well, but the DIP joint is not having a flexion. So there should be an injury to the FDP tendon at the level of zone 2 at PIP joint.
Aviral, can you describe the zones for our audience in simple diagrammatic on your hand?
Yeah. So the zone 1 is it's distal to the FDS insertion. The zone 2 is from FDS insertion up to the lumbrical. Then the zone 3 is the lumbrical. Zone 4 is the carpal tunnel, and zone 5 is proximal to the carpal tunnel.
Exactly. So, Saini sir, how you will proceed for the?
What is the duration when he has presented to you?
Now it is 6 weeks.
It is 6 weeks. You see, this is isolated injury to the FDP of the ring finger.
Yes.
So his first tripod is well functioning and intact. Now it depends upon the requirement of the patient, because a reconstructive surgery in this case, surgery in this case can be a short option of doing an arthrodesis of the DIP joint or a tenodesis, or it can be of reconstruction of the FDP. Now, reconstruction of the FDP at 6 weeks will require most probably 2-stage surgery. It may require a silicone tube insertion initially, and then the outcome may or may not be very nice. Since the whole composite grip can be maintained by a DIP, so basically I feel we have to explain the patient both the things and then proceed accordingly.
Purnima Patni madam, would you like to add something?
I tend to agree with Seni. You know, the tight tunnel that these tendons are going through. So it has to be really, really very meticulous work. And despite the best techniques, we have seen that the finger will get stiff. A better functional finger will probably be by just handling the distal interphalangeal joint and fusing it in a functional position. I would prefer to do that rather than embark on a repair of the profundus.
Okay.
And you know, it has not been a clean, sharp cut from your history. It sounds like it would have been a crush.
Okay. Anyone from Rahul Kotta sir?
Sorry.
So, madam, point is taken. Rahul Kotta sir, Kishore sir, or Mohammad Iqbal sir, do you want to comment? Vinay Goyal sir.
In our scenario, in our practice routinely, so patient usually want a functional joints, both PIP and DIP. Although at 6 weeks, we cannot promise them to have a functional joint even after the reconstruction. It is difficult to convince a patient of a good background for the arthrodesis of the DIP joint. Rather, they will choose to leave the finger as such. Most of the time, they insist for try a repair. So my submission is, even if we try for reconstruction of FDP at 6 weeks, what additional complication we do anticipate in such cases? This question is to all the panelists.
Nehete sir, could you comment?
Yes. If as Dr. Rahul said, if the families and the relatives are insistent, especially I find it young girls, if they come with this injury, and I tell them that I would like to explore the finger. I would like to see the status of the flexor tendon sheath and see the flexor tendon, what is its condition. What I have done in some patients, doing a primary flexor tendon graft of a palmaris longus, because the sheath is lying empty there. And what I use is a Hegas dilator to dilate the flexor tendon sheath in such patients. And then put a palmaris longus primary tendon graft from the palm to the fingertip and try to get the flexion. But whatever I have done, I mean, to be frank, in a rare patient, I have got complete DIP flexion. Always there is some deficit of the flexion and there is some deficit of extension in all these patients, whatever I have operated. But then, in spite of that, patients are extremely happy that their distal phalanx is flexing at the DIP joint. So I have done up to 6 weeks to 8 weeks, I have done a primary flexor tendon graft. If I find the sheath is badly damaged, But usually by such simple cuts, the sheath is not damaged to that extent. If it is sheath is not good, then I would put a tendon implant in a first stage and replace it by the tendon graft. If the family is insisting, but I respect Dr. Patni's opinion, many patients from a simple families, ordinary background, who will not be able to follow multiple surgeries or any complication of surgeries, I prefer to do DIP orthodesis.
Any role of musculoskeletal ultrasound? You have already mentioned that you would like to do.
Yes, I do it, and basically I can notice some adhesions, but it doesn't give me any prognostic indication of surgery, because prognosis doesn't depend on ultrasound. It is only a diagnostic modality. Diagnosis, I can diagnose whether the tendon is repaired or not, but I cannot diagnose whether the sheath is adequate or not. So it doesn't give any prognostic value. It is only diagnostic value. But yes, we in a palm, when there is a palm cut and there is one finger flexing, another is not flexing, there we get exact diagnosis whether the tendon is cut or if it is unrepaired, or whether it is repaired and if it is adhered. We can get that definite information. Or even in the proximal. Fingers, I find it difficult. I have still not adequate experience. With great difficulty, in fact, I'm trying to adapt. I find it difficult to give that much of time also, but then I'm comfortable in forearm and palm.
Sir, is any role of primary repair, end-to-end repair without graft?
No, after 6 weeks, no. It will get added again at the injury site.
Sir, what is the time limit for the primary repair? How long you can attempt the primary repair in such patients?
Up to 3 weeks, maximum up to 1 month. After that, it is impossible to accommodate the contracted FDP, which becomes little thickened because of the contraction. It is impossible to get into movement, and the flexor tendon sheath will not accommodate if it is retracted into palm. It is inadequate to accommodate the complete FDP in that finger. So beyond 3 weeks, I don't find it is possible. So at even 1 month, I have put a primary tendon graft, excise the remaining flexor FDP, distal to the lumbrical, and do anastomosis, do the Fpl repair at that level using palmaris longus, and insert it distally in the bone. So first distal insertion and then Fpl proximally.
Any fragment that is left behind with a good insertion means 1.5 centimeter of the length of the FDP that is remained already. Would you like to use that, or
No,
would you like to?
I don't use it, because the repair, if you do, it lies exactly on the DIP joint and it will make the DIP joint stiff. So what I do is I cut part of it. I leave around 6 to 7 millimeters of distal tendon, split it into 2 and put a palmaris longus into the 2 slips and do a good repair out there. In spite of that, I take a suture which crosses on the nail also. But I don't leave that distal 1 centimeter or 1.5 centimeter, because I'll tell you, the last distal pulley, A5 pulley, is so tight that it doesn't accommodate even the flexor.
Yes.
So if you try to put repair there, it is impossible to move, and your DIP joint, there is no point in repairing then flexor tendon at that level, because you will not have any motion in DIP.
So in this patient, basically he was around 27-year-old, and he was IIT professional, and he wanted his DIP to move. So I went for sonography, although it was suggestive of partial tear. And one thing that was good, that he found the flexor tendon was in the near about A2 pulley area. When I explored it, then I retrieved the tendon in the palm. And one interesting thing, I have found, and it is also described by the Teng, that they can extend the primary repair up to 5 to 6 weeks. There are two conditions, especially the flexor tendon is within the flexor sheath, so some vincula is intact, and if tendon is stretchable. So I tried this method, pass the flexor tendon through the pulley sheath. Although I vented the A4 pulley distally, only the proximal part of the A4 pulley was intact. And then end-to-end repair was done. But and I started. I usually follow the passive Duran method, not active mobilization. Although I do the 4-strand repair. Then same the thing which is felt by our panelists, that patient was having DIP joint movement, but there was no DIP joint movement. So this is the condition.
Little bit better than that.
No, basically it is flexion deformity at the
Flexion
DIP.
deformity, yes.
But no active excursion.
I think composite grip is improved, so that is why the patient is happy.
But the flexion at the PIP joint seems to be less than the previous.
Less than earlier.
So I have a question in this regard from Nehete, sir, that so one of the real risks in these sorts of surgeries is loss of FDS function, which was present preoperatively.
Yes.
So how do we modify our, like I also use the passive mobilization protocol. So how do we modify our post-op rehabilitation to at least maintain the FDS function, at least that is not lost? So we follow the active one in graft also, or something else can be done?
Aviral, are you working in NUH at present?
Yes.
Yeah, I was in NUH in 2006. So okay. And they have a excellent system of records, and in fact, I went there with the intention of learning their systems, that how they keep records. And
yeah, that's one of the things. Yes, yes. Yeah. So that's a good thing that I saw. But sir, unfortunately, now I have not seen any secondary tendon reconstruction here. They've got, I mean, neglected injuries they don't have here now. So,
so see, the best part is preoperatively, you should have, as I said, you should be able to completely extend the fingers and completely flex all the joints actively as well as passively. If you want to choose the patient for secondary flexor tendon reconstruction, if there is any deficit, you overcome it first. Secondly, what Patni madam also noticed, that the PIP function is hampered in this patient. That is because of the adhesions of the FDS and FDP with each other. And that is avoided only if you are doing early mobilization of the tendons. That's the only way to avoid it. I also used to follow, in fact, I am from Jhsa hospital, and we used to always follow the Kleiner traction, later on with Chow's modification, so that we get good inter-tendon excursion into the flexor sheath because of the Chow's modification, which is adding pulley at the PIP crease level. Sorry, the Palmer's crease level. But in spite of that, we used to always find it added more contractures rather than helping the patients. And when I came into my practice, I was following Kleiner's traction method, but then immediately within a year or two, I shifted to early active mobilization. But I realized by seeing my rupture of the tendons that I need to repair them very well. So I reviewed the literature and started repairing the tendons very well, very meticulously with 4-strand repair, so that it will not give way. In fact, to all my fellows, when I do a flexor tendon repair, I ask them to do a passive extension of the fingers and see whether my tendon is giving away or not. So if anybody, I was also trained in Jhsa, they used to be very finicky about touching the fingertip after flexor tendon repair. Now I ask them to do passive extension after flexor tendon repair and check the strength of the repair on table. If that strength is good, you can mobilize them even the same day evening. Normally, I don't go for an evening round late, so I mobilize them next day morning. But then the only difference which made in my methodology is doing the strongest repair possible and doing it meticulously, taking a good EP-tenon 6-0 suture so that there is no frayed ends of the tendon outside, and the strength is so good that you can mobilize them early, actively, without being afraid that patient will break the tendon repair.
Thank you.
Sir, yes, please.
Yeah. So we will continue with this discussion. So, Dr. Vinit, do you think any hope to improve with this?
I think rehabilitation only can further.
How to rehabilitate? How to rehabilitate?
This scar mobilization as well as little bit of intertendinous gliding that can improve. This is you are showing it at 6 weeks. I think this will improve eventually.
Yes.
When you continue with your this what do you call differential gliding of the tendons.
Okay.
So that is
Nehete sir,
vernal blocks and all these.
What I add to these patients is I give a dynamic extension splint for the individual finger, and I ask them to mobilize with the splint on and without the splint, both active mobilization. And I found that the spring-loaded extension splint, it breaks even the adhesions in between the tendons, and it improves. As you said, there is a flexion deformity of the DIP joint. There is inadequate flexion of the PIP joint. So if you passively mobilize the PIP joint flexion and actively you give a dynamic splint for the extension of the finger, it will definitely help and it can reduce. Let me see whether you have done it.
Sir, one question for the venting of the pulleys. Anything you would like to comment upon venting the pulleys, A4 or A2 pulleys to repair, because this is just exactly at the level of A4 pulley. So what is your take about, because the tendon, he's coapted the tendon there and it will be of full width. The tendon is complete tendon is there. It is not partially splitted. So it will be bunched at A4 pulley level.
I don't think there is a bunching or anything. It is simply adhesion which doesn't allow gliding of the tendons. Venting of the pulley, I also do 50% of the pulley if I find that my repair at that level might become a little tighter. 50% of the A4 or even A2 pulley I have sacrificed many times without any significant impact. But you know nature how it is. It will at least show somewhere that you have vented the pulley. It will. But then to improve your result, rather than making immobile finger, it is better to make it mobile. So you may vent. I prefer to vent the pulley rather than not venting it.
Okay, thank you.
So the same way, actually I discussed the case with our occupational therapist, madam, and the main the problem was that when we start the mobilization, what we do, we tell patient that move the fingers, and usually they move at the MP joint.
Yes.
Because that is the done by the intrinsic muscles. So what I want to share you that this thing that start your active mobilization with the DIP joint and proceed proximally. So as Dr. Vinit told that differential gliding or banner block exercises I started, and gradually I achieved this much flexion, and the flexion deformity also resolved.
Very nice.
you can see the 60-degree excursion is
Active
there.
flexion, yes.
Very good.
But on the composite fisting, although he is having 60-degree flexion, but on the composite flexion, there is loss of terminal flexion. As Nehete sir told that you may find this problem.
Yes. It always, you will have some deficit like this. The nature is, you can't beat nature in this, because this is a very complex structure of balance of the lumbrical muscle and the two tendons gliding in between. I'll tell you that even the lumbrical muscles will have some contracture because it was not repaired for almost 6 weeks. And that will not allow a tendon movement very freely. And that is why you will have some deficit either in the flexion or extension of the DIP. I have seen it, whatever trick I have done, whatever I have done, in a rare patient, I get complete flexion of DIP and complete action of DIP in all the in the patient. To be frank.
So basically, I would conclude this case that we can get good results if we are doing good rehabilitation. Although the good surgical techniques are required.
And
so I'm
rehabilitation protocol also.
Yes.
That is pretty much.
So just I'm going to share this complex problem to add the flavor of the discussion. So this young girl of 10 years, she presented after an electric burn, and she had this wound, which is extending at the base of the middle finger, and it is bone deep wound, and it is extending to the third web, and there is superficial wound over the index, and this is after debridement. As patient presented after 10 days and finger was surviving, so I was not courageous to explore the radial neurovascular bundle, but definitely under neurovascular bundle was not good. So basically we are not going to discuss the flap coverage. So I did cross finger flap, although Nehete sir will not be agree with me. He would have done some free flap. Simply I did the cross finger flap and it healed nicely.
Excellent result.
So now we are going to discuss the, because and after this, this patient fly away for 4 years, and after 4 years he presented with inability to flex his middle finger. All wounds are healed. She is doing with this trick. She is opposing the all fingers and making the fist, but there is no individual movement at the, you can see. So this is the point of discussion today. So Dr. Vinit, how would you like to proceed?
I think electric burn gives you the condition where the tendons eventually slough out slowly, and they are just vanish.
Tendons are lost in the initial debridement. Pulley was also lost. It was bone deep wound.
Bone deep wound. So if they are present, even they will vanish after a few days. You cannot do anything about that, and you have to recreate the pulley. First of all, test the fingers for the passive flexion, and if it is a completely supple finger, and then you have to.
Sorry, I have not mentioned it is quite supple.
Quite supple. Okay. So you have to reconstruct the flexor tendon, as well as A2 pulley, because I think A2 pulley, bone deep wound A2 pulley is already gone. So to prevent the bursting, you have to reconstruct the pulley. But after 4 years, you may have to reconstruct the A4 pulley also, because of it may be like a fallen cave. So
Agreed.
it's already.
So these are the difficulties that we need to reconstruct the pulleys, and it may require 2 stages.
Is there any flexion contraction in the DIP center?
It's there, but basically it is correctable deformity.
One thing,
sir, like Kishore sir or Vinay sir, do you want to comment at this stage, or you add up anything in the discussion?
I don't know, Amit, what you have done for this patient, but I have little more holistic approach for such patient. I will just ask her to accept the deformity and live with it. Because I have burned my fingers by putting this thing. For a surgeon like you, I don't know what you have done. You might have got good result, but for me, this thing is over out here, because she's got a good functional hand. I would not like to disturb her function further.
Sir, same question. I was asking to Amit, that what drives him to ask the patient to go for repair or reconstruct in such situations?
Let's see what he has done.
Sir, what would have been your management in this case had it come to you primarily?
Primarily?
Yeah, or after 10 days as it came to Dr. Amit?
Yeah, see, I'm very skeptical about electrical burns, and I always find that my fellow colleagues should get these injuries rather than me getting these injuries, these patients to me. But once I see such patient, I usually do initially a conservative management, so that because electrical burns, the demarcation of the gangrenous tissue is very slow, and I would go slow. Till that time, you keep the flexor tendons wet and try so that they don't necrose. If there is any possibility that they will necrose, then I would like to radically excise and put a primary free flap, as Amit said, and save the flexor tendons, and then try to mobilize whatever result you get. I would not repair any nerve in such patient primarily. If at all, I would do a secondary nerve repair. But flexor tendon, whatever flexion she gets and whatever extension she gets, I will ask to accept, because such patients with enthusiasm I have also attempted, but now I have a little more holistic approach that I will not touch now this patient further. Primarily, yes, I would do a free flap, try to mobilize, get the result. But then in spite of that, they get either a flexion deformities or tendon adhesions, incomplete extension, incomplete flexion. That is for sure.
Any sir, Patni madam, do you want to add something? What will be your approach?
Madam, you need to unmute.
Mute.
I said I would be afraid to touch it. I would probably garter the fingers and allow her to use them.
So I think ignorance is the blessing. So I was not aware about these complications. So
one thing, one question, Amit, anything about the length of the finger? I think it is shorter than the earlier one.
That's because of the flexion deformity.
Yeah, because of flexion deformity, and then second thing is because some effect on the growth also.
Yes, because of the nerve injuries. Because of the nerve injuries.
Yes. So basically, I attempted the flexor tendon reconstruction, and initially I planned for 2 stage reconstruction. And then initially I thought I will do the pulley reconstruction and silicone rod thing, and then second stage I will do the graft. But when I explored it, then I found one situation that its FDS FDP were found adherent to each other, and for 4 years they united well. So I remember a Russian technique where in the first stage what they do the repair of the FDS FDP, and then FDP can be cut proximally and it is flipped up distally. So intraoperatively, I thought, why not we can do this thing, because for 4 years it would have united, and now it can act as a vascularized tendon graft. And when I explored the distal end, then it was my surprise that although the A2 pulley was not good, so I used palmaris longus to reconstruct the A2 pulley, as you can see here. And whatever the fibrous tissue was there, I used to reconstruct the pulley. And because this was the vascularized bone graft, so I was confident that I would start mobilization early. And I inserted at the DIP distal level. And then as I'm continuously in touch with my occupational therapist, she is basically my teacher also. So she tells what to do now next, and I'm so keen to do rehabilitation. So I started my mobilization, and in the same manner. So initially the passive mobilization and the passive mobilization, as I told, that I start with the MP joint and PIP joint and DIP joint, and the active movements start from the distal to proximal. So gradually her excursion improving, and you can see this much excursion she got at the PIP joint level. And with the time it has improved, and now you can see 90 degree of PIP joint flexion. This is the normal, and at PIP joint 90 degree flexion. And then gradually the DIP joint movement also started. And this is the final condition.
Damn good result.
Good results, Amit.
Very nice.
So, as I told, ignorance is blessing. And accidentally I found the vascularized graft.
No, but it was.
I used this technique
to use there. Yes. Yes, patient and you both must be very happy.
Yeah, patient was quite happy. I was also happy. So I would take this opportunity to invite all you for our upcoming ISCHCON meeting at Jaipur on the 6th, 7th, and 8th October. And Dr. Nehete sir will be talking on the flexor tendon. He is moderating the flexor tendon session, and he will be having the talks. So we will get more opportunity to deal with the tendon injuries.
Until then, collect your questions to ask him all the questions.
Yes.
So
with this, I will hand over to our secretary, Dr. Rahul Kotta sir, because it is already 9:50.
Before he talks, Dr. Rahul, let me thank Rajasthan Orthopaedic Association and Dr. Amit to invite me to talk in this webinar. It was very interesting, good discussion. Amit also showed very interesting cases.
Thank you, Dr. Rajendra. Dr. Sani, would you like to sum up some take-home messages from today's webinar?
Yeah,
definitely. Yeah, please. For common orthopedic surgeons.
Yeah. One is that in this era of the state insurance, where the codes are put in the name of tenolysis and tendon repair and everything. I would like to say that if you are not well versed with repair of flexor tendons, please don't repair them, because then it becomes very difficult and it is very cumbersome for the patient also. Nehete sir has given a good talk on that, and if we are all determined, it can be learned. This art can be learned, and then it can be practiced as well. But it requires a lot of patience and a lot of therapy. Like you would have observed in cases of Amit, the repair has taken a lot of time and a systematic approach towards the therapy to get those results. So just doing the repair is not sufficient. It requires a whole lot of effort on the part of the surgeon and the part of the therapist as well. So this message should be very clear. Secondly, I think doing these injuries may not be very difficult, but then you need a setup. It's not, these instruments of repairing these things are not easily available with anybody who is not doing it. And handling these tendons with large instruments and improperly can create more fibrosis and more problems. So I think that is the main message I would like to give.
Thank you, Dr. Sani. So the crux of today's webinar is a proper diagnosis about the situation, proper counseling of the patient, timely refer to a higher center with a good specialist who can repair such injuries. Do not do the heroic surgeries if you don't know, you don't have the setup to deal with. To get a proper result out of such kind of injuries, occupational therapy. But definitely these repairs can be learned, can be practiced. If you are well, if you can trained about this, definitely you can start doing both these kind of surgeries. So thank you so much to all the faculty members, especially Dr. Rajendra from Nashik, for nice presentations and good discussions and good points, good words of wisdom. Thank you, Madam Purnima Patni, for giving the guidance on few of the cases. Thank you, all the panelists, for a nice discussion. Our moderators, Dr. Sani and Dr. Amit Vyas, who hold this webinar live. Thank you, everyone, all the audience. Would also like to thank OrthoTV for providing us the platform today for this webinar. So from Rajasthan Orthopaedic Surgeons Association, for last few words for Thanksgiving, I would also like to invite Dr. Kishore Chandani for words of conclusion. Dr. Kishore, sir, please.
Thank you very much, everyone, the August faculty we had, and we were very fortunate to learn the tips and tricks of flexor injuries and the nuances of this particular topic. It's such a challenging topic, and everybody feels that the tendon is in front of us, in front of me, and I must repair it. But it is not like that. It is easier said than done, and we have to be very cautious, and we should not make the things difficult for the final surgeon. So be careful, all the audience, that if you can do it, then only do it. Otherwise, just refer it to the higher center or the places where it can be done. And thank you so very much to all of you to give the lovely active participation and giving us all the tips and tricks and your expertise. Thank you so very much once again, Rosa, and thank you so very much the faculty from Dr. Rajendra from Nashik and all the people from Jaipur, and especially Madam Patni, sparing valuable time and giving us the blessings. Thank you, and thank you very much once again.
So thank you, everyone. We'll have a next meeting next month with another topic. Till then, stay safe. Thank you. Bye-bye.
See you in October.
Thank you, sir.
Thank you. Thank you so much. Thank you.
Thank you, sir. Thank you very much.
Thank you. Bye-bye.